Okay, guys, it's RT210J. It's Mr. McCarthy. It is September the 18th, 2020. We are now to the point of restrictive diseases. That's what this lecture will focus on. We did obstructive diseases yesterday, and we did incentive spirometry and positive pressure breathing on the day before that. Just a quick reminder that this Monday is your lab day. Okay, I sent everybody an announcement, and I sent you an email of the same announcement. Okay, so the announcement is in your Canvas, and I also sent you an email of what to expect for Monday, and as far as being able to make up some labs on Tuesday and the exam on Tuesday. So all that's in the announcement. If you have any questions, please refer to the announcement or the email. It's all in there, everything you need to know. I have some requirements that you need to contact me on, and that's all laid out in the announcement. All right, so restrictive diseases. We talked about how obstructive diseases is when the patient cannot exhale properly. All right, so if you can't get the air out, it's considered to be a obstructive diseases. And we learned that there are several obstructive diseases that would cause this or cause COPD, and they are the C-babe diseases. We talked about the manifestations, the symptoms of them, how we treat them. Please be sure to go over those carefully because this test is involved with a lot of things. So you got to know how to treat your obstructive diseases. You got to know how to be able to differentiate between which one, emphysema or chronic bronchitis, or asthma and bronchiectasis, right? And then bronchiectasis had different types of bronchiectasis, right? And then we had emphysema has two types. So you have to be able to understand those, study those within your lesson plan and your PowerPoint. The PowerPoint is there for you to look at several times, as well as this lecture. I will tell you that most of the tests will be consistent of what's in this lecture, because we have hyperinflation mixed with obstructive and restrictive. A lot of this information will come directly from this lecture and the PowerPoint, but you are still required to read because there may be some information and testable questions from the reading. Again, the Barre Mark 7, those little ventilators that's in the reading, the Bennett PR2 and how you do this and that, those are not on the exam because the NBRC no longer tests students on those machines. You may see it in the lab. He may show it to you just, because it's like a museum type piece. We don't really use it anymore, but it's the pioneer of hyperinflation. And so you won't see that on the test, but so if you see that in the reading, don't worry about that, but focus on the other things. Really, really wonderful PowerPoint for hyperinflation that I designed that's going to hit all of the key points. So be sure that you look at that, take the notes, watch it over and over again, whatever you need to do. So now we're at the point of restrictive diseases. And when we have a restrictive disease, we can't get the air in, okay? There's several reasons why the patient won't be able to inhale a deep breath because of a restriction, okay? When you restrict access to something, you don't allow them in. You don't allow somebody to enter. It's restricted area, right? And so there's reasons why the human body cannot inhale the amount of gas that's normal for somebody who's normal. And so there's several types and reasons, and we're going to get into those today. All right. The objectives, of course, you'll be able to discuss restrictive disease states, interpret the pulmonary function data, right? Because we talked about in obstruction, patients will have a higher FRC because they can't get the air out, right? The residual volume, or the RV, will be higher than a normal person because they can't get the air out, right? Well, if I can't get the air out, my volumes are going to be higher than somebody who doesn't. Well, that's not is kind of the opposite for restriction. And you're going to learn those basic PFTs, which are the IRV, you know, the IRV, IC, the ERVV. All of that is like pulmonary function, right? Total lung capacity. Those capacities are functions of the lungs. What can you do, right? And those values that you learn for obstructive will be slightly opposite for restrictive, right? List laboratory values for those restrictive diseases. Differentiate between obstructive and restrictive diseases. You got to know which, if I give you a test question and gives you a disease, you got to be able to tell me whether that's a restrictive disease or an obstructive disease. And then classify those restrictive diseases as skeletal, abdominal, neuromuscular, or pulmonary, okay? So restrictive diseases are broken down into skeletal, abdominal, neuromuscular, or pulmonary. And each one of those categories have a list of diseases that fall within them, all right, that would cause a restriction. All right, again, you have skeletal, abdominal, neuromuscular, and pulmonary. Those will be reasons. These are the categories of restrictive diseases. All right, so we'll start with skeletal. The skeletal diseases that are associated with restrictive disease are kyphosis, scoliosis, kyphoscoliosis, pectus excavatum, and pectus carinatum. Right? Kyphosis, scoliosis, kyphoscoliosis, pectus excavatum, and pectus carinatum. And how do they manifest? Well, they manifest with a decreased vital capacity, right? A decreased total lung capacity, right? Because they can't get the air in. So if they can't get it in, then their volumes are going to be lower than the regular person, right? You got normal, then you have low volumes in your restrictive diseases and high volumes for your obstruction. So that's how that works. That person will also suffer from an increased work of breathing. You have a decrease in compliance. If I have a restriction, that means I can't get the air in. The lungs will not do what I want them to do. If I want them to inflate, but they can't or won't, that's because they have a low compliance. Remember, compliance is what if the lungs will do what I want them to do. And someone who has COPD, they have a higher compliance because the lungs are kind of floppy. They'll blow up to what I want them to blow up, right? They have a higher compliance, real floppy. But something that has a low compliance is rigid or tough, restricted, right? Like a dry sponge. It won't stretch because it's hard and restricted. You're going to learn that in skeletal disorders, if my skeletal and my bones are not functioned properly or they're structured wrong by birth, that kind of blocks my lungs from expanding. And so you're going to see some of those as we go on. So remember, restrictive diseases are synonymous with a decrease in compliance, and obstructive diseases are indicative of higher compliances, right? All right, usually not clinically significant unless combined with other diseases. Treatment if needed, and you can also do surgical correction. So our skeletal diseases can be corrected with surgery if needed, right? They're usually not too bad unless they're combined with some other disease, right? So let's see some of them. Look at this older picture here of a young man who looks like he has kyphoscoliosis. Well, let's look at it. This is a normal guy here, up and down, straight up and down. Well, then kyphosis is the hunchback. If you ever see somebody with this hunchback, this is considered to be kyphosis. All right. Somebody who has this indentation way at the bottom of their spine is known as lordosis. All right. It's the sway back appearance. Kind of like with some of the females who are on TV, they try to mimic this look so that they have a small waist and a bigger backside. But that is really a disease state of the skeletal muscles or the skeleton, right? And that's called lordosis. These are restrictions. okay? And if I look from the back, and that's the hunchback part, and this is the left or right part. Normal right here. Then scoliosis is a lateral curve of the spine, like an S, right? Scoliosis, right? Scoliosis. It's almost like a little S when the vertebrae is shaped like an S. That's called scoliosis. When that happens, it's hard for your lungs to inflate because your rib cage is curving. Okay, the lungs are normal, they're natural, but they can't do what they want to do or you want them to do because they're blocked by this deformity of the vertebrae. So scoliosis. But what if I have both? What if I have scoliosis and a hunchback? That would be kyphoscoliosis right here. When you have hunchback and you have the S-shaped vertebrae, that crumples up the lung, right? There's not a lot of space for that lung to expand. And so that's why it's called a restrictive disease. It's restricting the lungs from inflating like they should. So this is a really terrible, this is a really bad case here. But this young man seems to have kyphoscoliosis. He got hunchback and it's curved. Look at that. Look how that's curved. That looks like it hurts, right? And so his lungs don't inflate. No, they have no room to inflate like a normal person's lungs would. And so that's why it's called a restriction, right? Next one is called pectus excavatum. When you think about somebody or a company that's doing a new, building a new shopping mall or whatever, they have to first do excavation, right? They have to excavate the land, dig out the dirt and make it level. Well, this young man's chest looks like somebody took a forklift or a backhoe and just dug into his chest. That's how you have to think of it. Dug into. That's why we show you this picture right here. It's like kind of like somebody just dug into his chest. That's called pectus excavatum because it's like excavation, right? And it looks like, you can just push your hand or your fist in between his chest, and your hand or your fist will kind of sink into his chest. With that type of situation, then his lungs cannot inflate well because his bones are pushing up against his lungs. So that is a restriction. Pectus carinatum, we also known as pigeon chest. Pectus carinatum or carinatum is known as pigeon chest, right? Look at this. His chest and his sternum is coming outward, right? It's like a pigeon walking around with his chest poked out. That also causes a restriction on the lungs. They cannot expand normally because of the curvature, frontward curvature of the chest. This is called pectus carinatum, pigeon chest. All right, so that is those were the skeletal category of restrictive diseases. So we had the category of skeletal, which had its types. You had pectus carinatum, you had pectus excavatum, and you have scoliosis and kyphoscoliosis, right? Those are the skeletal restrictive diseases. Now we're getting into the abdominal category of restrictive diseases. So you'll be like, well, how is abdominal problems cause me a restriction on my lungs? Well, obesity. If somebody has a very, very large stomach, right? That stomach is pressing against the diaphragm. And if the diaphragm is being trapped, it can't expand, and the lungs therefore cannot inflate like they should. So obesity, also known as hypoventilation syndrome, because you're not ventilating well because of your weight. So if somebody is laying on his back or laying there and his stomach is huge, right? You've seen My 600-Pound Life. If you may have seen that story or that show, right? It shows a lot of very, very obese people, and they suffer from hypoventilation syndrome. That's why most of them use a CPAP machine to force air in, because They have so much weight on their diaphragm, right? So that's an abdominal issue. What if they have a tumor in the abdominal tumor? Sometimes you can have a watermelon-sized tumor in your abdomen, and that is keeping your lungs from inflating, right? You could be full. Have you ever noticed when you ate a lot of food, and you kind of sit back and say, "Ooh, I'm full," right? You have to take a sigh breath because your breathing is being blocked because your stomach is so full. All right. Pregnancy, somebody who is advanced, like 9 months pregnant, 8 months pregnant, with twins or just with a single baby, you can have a lot of weight in your stomach and your abdomen area that is restricting your lungs. Also, the last one is ascites. Ascites is serous fluid in the peritoneum. When serous fluid gets down into the peritoneum, which is the space in the abdomen, and starts filling up with fluid, well, then now you have a huge watermelon size of fluid in your abdomen, which is restricting your what? Lungs. So those are some of the abdominal category diseases for restrictive problems. And how do they manifest? Well, if you have a lot of weight on your diaphragm, that's called decreased diaphragmatic excursion. Your diaphragm cannot do what it's supposed to do, which is descend in order for your lungs to inflate. Well, we know that our diaphragm sits above the stomach and under the lungs. So if the diaphragm is not able to descend because you got so much in your stomach, then the lungs therefore cannot inflate, and that would be a restriction. Again, they have decreased vital capacity, decreased total lung capacity, and a decrease in compliance. Most all restrictions have the same PFTs, okay? And of course, an increased work of breathing. So let's look at a couple pictures of that. So the abdominal obesity syndrome, or also known as Pickwickian syndrome. Pickwickian comes from the Charles Dickens novel called The Pickwick Papers. This young man here has a large stomach. It's very, very big. Almost, you call it a beer belly, or whatever the nicknames they give them. But when you have a very, very large stomach, it presses against the diaphragm. So if you look at here, his diaphragm is kind of sitting way up here, right? His diaphragm is kind of above his stomach, and so he doesn't have much room to inflate. So that's why he's on a CPAP machine. He's on a CPAP machine to help him breathe and force air into those lungs because he has so much weight on his stomach. Obesity places a major strain on the heart and the lungs as well. And sleep apnea is very common with obesity. So people who are very obese, well, 9 times out of 10 have sleep apnea. So they have to use a CPAP machine, okay? This is an example of some tumors. This guy here has a huge tumor, right? I think this was in Bangladesh or whatever. Usually the third world countries suffer from stuff like this. But this is a huge tumor on this man's stomach, in his abdomen. So you can imagine the problem he has with breathing. Look at his little bitty legs. See how small he is, but look how big the tumor is. It's huge. And since he's in a third world country, it's hard for him to get things like this removed. This is another example of an abdominal tumor. I don't know how much restriction this one would cause, but I'm sure it probably causes some. And you don't know how deep it goes into the body. And then again, this is another example of a young man on his back that has an abdominal tumor. So abdominal tumor is an example of a restrictive disease in the abdominal category. Pregnancy, we all know pregnancy. This one here looks like more than one baby to me. Now, I don't know if that's one big baby or it could be twins, triplets. That's pretty big. But if you are pregnant, late in pregnancy, your diaphragm is way up here and it cannot excurve. It cannot go down like you wanted to suck those lungs open because all it is. Okay? That's all it is. All right, ascites. Ascites is fluid in the peritoneal cavity caused by reduced venous return. So if you have reduced venous return, remember we talked about the heart and we talked about blood goes back to the right side of the heart, returns from the body. Well, if that for some reason is decreased, then you can start to build up fluid in your peritoneal space, which this looks like an underground cave, right? It kind of looks like a boat will be flowing through here, go left or right. But this is actually inside of his abdomen, and this is full of fluid, right? This is serious fluid that has filled up in his peritoneal space, and this kind of looks like this. Look at this. This is all fluid. This is not a tumor, but this is fluid. And so this person cannot fasten pants. He has to wear what? Suspenders. And this is how we remove it. We take a syringe, we insert into the peritoneal space and drain the fluid. But if you don't fix the problem, it's just going to fill up again, okay? So that reduced venous return from heart disease, venous flow obstruction, lymphatic flow obstruction, sodium retention, right? Doing a lot of salt, cirrhosis of the liver, right? Would increase resistance of blood flow through the liver. So cirrhosis from alcohol, you know, somebody who drinks a lot, or if you drink a lot, you are destroying the liver, right? A lot of Tylenol can destroy the liver. You have to be very careful. If you're taking pain pills, most pain pills have Tylenol, which is acetaminophen, which can damage the liver, okay? So be very careful. So ascites, fluid that builds up in the peritoneal space or cavity, can cause a restriction. The lungs can't do what you want them to do, okay? All right, that is it for the abdominal category. The next category of restrictive disease is neuromuscular. Neuromuscular, okay? These are different things that happen from the brain. The brain causes different dysfunctions in the body, which can lead to a restrictive disease. So the types of neuromuscular diseases are Myasthenia gravis, Guillain-Barre syndrome, paralysis, polio, and tetanus. Myasthenia gravis is a paralyzing, well, we're going to talk about each one, but these are the ones here. How do they manifest? Of course, poor inspiratory muscle function. You're going to see why. Rapid, shallow breathing with low vital capacity. They're breathing faster, but it's shallow because it's weak. They're weak. Microatelectasis, right? Little patches of atelectasis all through the lungs. VQ mismatch and hypoxemia. These are the things that will manifest to let us know we have a neuromuscular disorder going on, right? So we have myasthenia gravis, Guillain-Barre syndrome, paralysis, polio, and tetanus. So myasthenia gravis, this one and Guillain-Barre are really some fascinating diseases they come on just gradually and just, you know, out of nowhere. And they're amazing. Anybody can get it. But typically it affects women 30 to 40 years old. And so this is the claim to fame for myasthenia gravis. It's paralysis that starts from the mind to the ground. So look at this, MG, mind to ground, mind to ground. So the paralysis starts at the brain or the head, right? And then starts coming down all the way down to the feet. So they start feeling the eyelids start getting kind of droopy, right? And then after that, they have problems swallowing and speaking because the paralysis has now reached their mouth area. Then it goes down into the lung area. So it starts to affect respiratory. Now, this is what makes it restrictive, because once it gets to the lungs, we have paralysis. So now we can't force ourselves to take a deep breath because we're almost paralyzed. The lungs have become paralyzed. And so now we can't get that breath. So that's a restriction, okay? It manifests as of course, decreased vital capacity, a decreased total lung capacity, gradually decreasing the inspiratory capacity and tidal volume is gradually, right? Because when it starts at the head, you can breathe fine. But when it makes it down to the lung area, then you start to have some lower volumes because you can't get the air in, because you are having little bouts of paralysis, right? Respiratory hypoventilation, which of course builds up the acid, right? What are the causes and effects? The causes of myasthenia gravis is a decreased acetylcholine transfer. Now, we said that acetylcholine is the neurotransmitter for the parasympathetic nervous system. Epinephrine is the neurotransmitter for the sympathetic nervous system. You learned that in pharmacology. Well, we want acetylcholine to do, its job, and we want epinephrine to do its job. But if we have a decreased amount of acetylcholine transferring, then that can cause myasthenia gravis, okay? And so when you think about that, if I have a patient that is experiencing we know that he has myasthenia gravis. So we know he probably has a decreased acetylcholine transfer in the synapse, right? For some reason, the acetylcholine is not flowing back and forth like it's supposed to. Then if I look at what medicine might I discontinue that I'm, as a respiratory therapist, are giving him, right? So what medicine could I be giving him that could be aiding in this blockage of acetylcholine, okay? What medicine could I be giving him that I probably need to stop because it may be enhancing these effects of the decreased acetylcholine transfer? You can just say it out loud if anybody's on here that knows. Think about the drugs that we give. Think about the drugs that block acetylcholine. What respiratory medicine that we give blocks acetylcholine? All right, nobody knows?
You said what?
What medicine that you give as a respiratory therapist that blocks acetylcholine? What is the specific medicine? Because if they're on that medicine, I might need to stop giving that medicine because of this myasthenia gravis. This is something you should know.
It's the medicine.
If you just got a wonderful grade in pharmacology, you should know that one right off the top of your head. What medicine do I give that blocks the effects of acetylcholine? Judith, do you know?
No.
All right. Anticholinergic drugs are drugs that block acetylcholine. The only anticholinergic drug we give as respiratory is Atrovent.
Okay. Well, I would have been right if I would have said that. I was gonna say Coven or something like that, but it's Atrovent. Okay.
Ipratropium bromide, which is trade named Atrovent, is an anticholinergic drug that we give that blocks the effects of acetylcholine, because acetylcholine also causes bronchoconstriction. And so if I'm giving a patient and they're on Atrovent, right, Duonet, which is albuterol and Atrovent, and they're getting it every 6 hours, every 4 hours, and we notice that they are suffering from myasthenia gravis, which happens because of a decrease in acetylcholine, well, then I might want to consider stopping giving the Atrovent because I'm making it worse, because I'm blocking acetylcholine, right? So not only is he naturally having a lower transfer, but I'm throwing more medicine on it that blocks it even further. So those are the kind of things that you have to be able to do as a therapist. You got to be able to look at what your patient is on, what you're giving him, and how they affect the body. So when you see that the patient is on a myasthenia gravis, has that, and you know it's because of a decreased acetylcholine transfer, immediately in your mind, you should say, oh, I need to stop giving this Atrovent. That should come into your mind immediately. Okay, that's how you have to work. You have to be able to move like this. Okay, this is diagnosis and treatment. This is what you call therapy. All right. So also weakness decreased with repetition of muscular contraction. A patient may have acute cholinergic crisis. See, they're having a cholinergic crisis. They don't have enough acetylcholine.
Mr. McCarthy.
Yes.
So it's Atrovent and atropine. Is that what it is?
Those two are, but atropine is not a respiratory medicine. It's an
That's for
anticholinergic.
nurses, right?
Huh?
That's for nurses, the atropine.
Yeah, that's what the nurse would give to raise the heart rate back up.
Okay. And,
Yeah,
okay.
so those two drugs, atropine and Atrovent, are both anticholinergic drugs.
Well, a lot of these medical names for the medicine sound alike.
Some of them do, but that's why you have to know them. You have to know them. You can't go in there saying acetylcysteine and you meant acetylcholine. You can't do that. It's like saying your left from your right. You have to know them.
Okay.
All right, so neuromuscular, the next one, we're still talking about myasthenia gravis. This is kind of the treatment for it. The treatment for it will be drugs that prevent the breakdown of acetylcholine, right? So I don't want to break down the acetylcholine no more, so I need to stop giving the Atrovent. If they're on Atrovent, I'm just going to switch them to albuterol only, all right? Because it's an adrenergic drug, so I need to just switch them from the duo nib, which is albuterol and Atrovent, take the Atrovent out and just give albuterol, because the Atrovent that I'm giving is aiding the breakdown of acetylcholine, okay? And this person needs his acetylcholine. That's why he's suffering from myasthenia gravis. So we can also give drugs that are that prevent the breakdown of acetylcholine. We can also put them on a ventilator, depending on how bad it is, right? You might have to put them on a ventilator, because once it becomes paralyzed in the lungs, you got to breathe for them. You're going to have to monitor their vital capacity and their tidal volume for deterioration, right? So as the tidal volume is getting lower and lower, we know he's getting worse and worse. So once the tidal volume starts going back up, his vital capacity is improving, then the weakness or the paralysis is leaving the lung area and headed on down to the feet and the legs, okay? Because all we're concerned about is respiratory is the breathing, right? So this is a picture here of the neuron, right? And this is the synapse, this area where acetylcholine goes back and forth on the parasympathetic side, right? The neurotransmitter is acetylcholine on the parasympathetic nervous system. Norepinephrine would be the transmitter on the sympathetic side, right? So in this case, this patient is suffering from a lack of acetylcholine. And so that's what causes the issue, all right? The myasthenia gravis. So that's what I'm saying. You have to be able to say, okay, well, he got myasthenia gravis, but you keep on giving him Atrovent. That's like putting somebody in the water and you know they can't swim. It's like, what are you doing? You have to notice these things, guys. You have to notice it. All right. Again, we may have to put them on the vent if we have to. All right, Guillain-Barré is just the opposite. Guillain-Barré is ground to brain, G to B, G to B. So that's ground to brain. So that is a paralysis that starts from the ground, usually affects your legs and your walking, and then your stomach area, you know, using the bathroom area, gets a little paralysis there. Then it makes it along to the lungs. Then you start having those issues with breathing. And then finally the head and eyelids and the droopy lips. Okay, so the paralysis goes from the ground up to the brain for Guillain-Barré. Myasthenia gravis, it goes from the mind down to the ground, right? MG. Now, the causes of Guillain-Barre are different. Guillain-Barre is ascending paralysis from the ground to the brain. Initially, you have leg weakness, difficulty walking, right? Then it gets up to your lungs. You have failure of your ventilatory muscles, autoantibodies. This is what happens. You have autoantibodies that cause demyelation of the nerve, rendering the nerve unable to carry impulses to the muscles. So let me show you that again. This right here is the nerve. This is your neural nerve, okay? This is the nerve here. This is the myelin that protects the nerve, right? Now, when that myelin becomes damaged, also known as demyelation, it's breaking down. This is what it looks like. See, demanaged or damaged myelin is all tore up, and that leaves the nerve fiber exposed. And if something breaks that fiber, that nerve fiber, it stops the reception. So when it's not protected anymore, now your impulses become weak. Sometimes they stop completely. Sometimes they fire back up. It's just all messed up. It's kind of like having your charger, right? You know how sometimes we have a phone charger and you got to hold the charger a certain way for it to do right. If you let go or it falls, you know, you turn it the left way or you don't hold it just right, it doesn't have that flow of power. That same thing happens with your nerves. If your nerve myelin, which protects the nerve fiber, if it's exposed, then you don't get those signals like you would if it was completely protected. Okay, so this is another picture here. This right here is regular myelin. This is nice right here, but this one, look, it's all tore up. So now anything and everything is able to affect that nerve that's in there. It's all, you have these antibodies that are growing on the myelin and destroying it, right? They're growing on the myelin and they are destroying the myelin, which leaves the fiber exposed, okay? So those autoantibodies, they cause demyelation. They latch on to the myelin and start eating it, right? They start eating it, and that causes demyelation of the nerve, rendering the nerve unable to carry impulses. So when you hold your charger, if you don't hold it just right and you let go, it stops. The power stops, no longer charging, okay? It usually 2 weeks after upper respiratory infection. That's usually what happens or brings it on. You get some type of upper respiratory infection, and then a little bit later, your body starts making these autoantibodies, which latch on to the nerves, right? The brain nerves, and they render the nerve unable to carry impulses to the muscles. So your respiratory muscles aren't able to function, right? Even the phrenic nerve. Remember, the phrenic nerve is the nerve that goes to the diaphragm. Well, if those antibodies are on the phrenic nerve and start eating away the myelin of the phrenic nerve, then the phrenic nerve can't fire to the diaphragm. And if there is no firing to the diaphragm, there's no breathing, okay? So that's what's happening. That's what's happening with Guillain-Barre. Now, what causes this upper respiratory infection? Usually caused by a foodborne infection, right? You can get it from just a regular respiratory infection, or you can eat something that that's not cooked properly, right? A foodborne infection, like it says of Campylobacter jejuni, commonly found in shellfish, milk, and poultry. So your shellfish, your shrimp, your lobster, all of that, your milk products, and your chicken, they have Campylobacter jejuni, which is a kind of like a bacteria that if you don't cook your food well, it can get in your system. If that gets in your system, your body's going to start making antibodies to fight it. But those antibodies start latching on to the myelin of the nerve, start demyelating it by destroying it, and that leaves that nerve wide open. And once you do that, you can mess up your impulses to your muscles, okay? Approximately 1 in every 1,000 cases of campylobacteriosis cases leads to Guillain-Barre syndrome. You don't have to know that. You don't have to know the percentage of the cases. Just know it does, just like any other restriction, have a decreased vital capacity, a decreased tidal volume, and can cause respiratory acidosis because your respiratory muscles are weak and paralyzed, and you can't blow off your CO2. So that is a restrictive disease. It's because the reason it's restrictive is because now when I want to take a breath, I can't because the nerve impulse is not there. So if my lungs won't do what I want them to do, that's a restriction, period. That's a restriction. All right. As treatment for Guillain-Barre, treatment. Now let me make this side point. Restrictive diseases don't have to be directly related to the lung itself. The lung could be perfectly fine. But you notice, you've learned that the restriction comes from other things that keep the lungs from doing what they're supposed to do, right? Like kyphosis or scoliosis, those skeletal issues can keep the lungs from inflating. The lungs might be perfectly healthy, but the skeleton is what's keeping it from expanding. So that's a restrictive disease. The abdominal issue, when your stomach is too big for whatever reason, the lungs are fine, but the stomach and the abdomen is the problem, which keeps the lungs from inflating. So that's a restriction, right? Neuromuscular issues like the Guillain-Barre, the Myasthenia Gravis, right? Or straight up car wreck and you sever your spinal cord, right? Your lungs are fine, but the other issues are keeping your lungs from doing what you want them to do. So that's a restriction, okay? So how do we treat Guillain-Barre? Put them on a ventilator until the return of function, because once the paralysis, because Guillain-Barre goes from the ground to the brain, right? So once it passes your lungs and goes on up to the head, the myelin and everything starts to get back healthy, okay? They start to return to function. And so you'll be on the ventilator until you can breathe on your own again. The paralysis leaves, right? So we put them on a vent, watch them until they are able to breathe spontaneously again, and then we can take them off the ventilator. Neither Guillain-Barre or Myasthenia Gravis is usually deadly, right? It just sucks. You be in a hospital, but it usually doesn't kill you, okay? We also want to mobilize those secretions by hydration, right? Either using an ultrasonic nebulizer or a small volume nebulizer, positive pressure breathing, or CPT, because once your lung function or your respiratory muscles are not able to do what they're supposed to do, you can't cough, right? It takes strong muscles to do a good vital capacity for a cough, right? So that's why we learned that we use these other modalities when you don't have the muscle strength to facilitate a cough, right? It takes muscles to be able to take a deep breath in and force it out in order to cough. So in the patient with Guillain-Barre and Myasthenia Gravis, when it is at the height of the lung area and they can't breathe, that means they can't cough either. And you have to make sure you keep that stuff out of the lungs. We can also give them what's called immunoglobulin. Immunoglobulin attaches to those autoantibodies to prevent them from further eating away your myelin, okay? We can give them IV immunoglobulin, and that will attach to those autoantibodies that are on the myelin and keep them from further damaging the nerve, right? We can also do what's called plasmapheresis, where we remove all the blood from the body. All the cellular components are preserved, and the patient receives antibodies, protein, and immune complexes back. So it's kind of like washing the blood, almost like dialysis. When somebody's getting dialysis, all your blood is coming out, it's scrubbing it, getting rid of the waste, and it's giving you pure blood back. That's what dialysis is, because the kidneys can't do it. That's what the kidneys are supposed to do. Filtrate and get rid of toxins, right? Well, if the kidneys are not working, we have to bypass the kidney and put you on a kidney machine, which is the dialysis. So plasmapheresis is really, really close to dialysis, except it doesn't have anything to do with the urine, okay, or the kidney. It just takes the blood out the body, wash it up real good, put those immune complexes and antibodies back in, proteins, and give it back to you to help get rid of those antibodies that are eating away your myelin. So we treat it with the vent. We immobilize them secretions. We can give them immunoglobulin, and we can do plasmapheresis for Guillain-Barre. All right. The last neuromuscular disease or issue is spinal cord injury. Very common sense. You have a car wreck and sever that spine. Anything below that spine area that you severed, you cannot do anymore. Okay. So let's look at it. The cervical spine, the thoracic spine, the lumbar spine, and the sacral spine. You have the cervical, that is the neck part. It's usually C1 through C6, I believe. That is your cervical spine. Then the thoracic would be like the thoracic cavity area, your chest area, you know, where it would be if it was in the back. Thoracic is 1 through 12. So you have T1 through T12. Cervical will be C1 through C6, right? And then lumbar will be L1 through L5. Anything that's severed below that, you can't do no more. So it's trying to show you where the red is what you can't do no more. Okay? So if you have a car wreck and you hurt your cervical spine, it breaks between your C1 or your C4, like C4 injury, total quadriplegia. You can't move your arms or your legs. And look at all this. That's your chest too. You can't hardly breathe on your own. You have to be on a machine to breathe for you for the rest of your life. That's why you should wear your seatbelt. Be very careful. No drinking and driving. And you have to drive for other people because they may hit you. So if you break that C-spine, right, nothing's going on. You can turn your head left or right, but that's it. You can speak, talk, but that's it, right? You're going to have to breathe for you, right? And if you're breathing through if you're on a ventilator, then in a tube in your throat, then you won't be able to speak either, right? What about C6? If I break mine way down to C6, also quadriplegic, right? You see, you have a little bit more. Look at, see the red? You got a little bit more love in there, but still, I would hate that, right? What if you break your spine in the thoracic area? So let's just say at T6, see, this is T1, 2, 3, 4, 5, and 6. You have a car wreck and it severs your vertebrae, your spine right here at T6, then you may be able to breathe a little bit, but everything down here is gone. So you paralyzed from like the mid-chest down. So you can move your arms and you can move your neck. You may even be able to breathe. But using the restroom and walking is gone, okay? And then, of course, if you break your lower back, you have your legs, everything from the waist down is gone, okay? So that's what this picture shows you right here, okay? So the higher the injury, the greater the loss of function. So if you break it way up here, pretty much everything is gone, okay? So it's very, very, very important to wear your seatbelt. So if I break that, why is that a restriction, right? Because I can't make my lungs do what I want them to do no more. So that's in essence a restrictive disease. It's restrictive. The lungs are fine, but you can't control them no more because you broke your spine. So now it's a restriction. All right, so spinal cord injuries, the inability to move secretions. That's how they manifest. You need to be able to generate approximately negative 40 centimeters of water to generate enough pressure for a cough. So that's being able to take that breath in to be able to cough out. You need to be able to at least pull, right? And if you looked at the lecture from yesterday, what is this called? Negative 40 right here. What is this called? What did I say this was called in the lecture? If you watch the lecture, you would know what this is. To be able to pull negative 40 centimeters of water in order to trigger a breath or generate a cough or whatever. But that pulling motion, what did I say that's called? Okay, it's called a NIF, negative inspiratory force. So if you watched the video yesterday, you should know that. The NIF, the patient has to be able to suck Remember we talked about, I talked about sucking milkshake through a straw. That sucking action, that pulling action is enough to be able to generate that negative force in order to suck that milkshake through the straw. Okay, so and what they're telling you is you need to be able to generate at least negative 40 centimeters of water to generate enough pressure to get behind a cough. And since you have a spinal cord injury, depending on where it is, it may be very, very weak or gone. And if you can't do that, then you cannot get rid of those secretions. So we have to get them out for you, right? No Valsalva. Valsalva maneuver is kind of like the gag reflex, right? If you are paralyzed, I may stick something down your throat and you don't gag at all. If the patient is suctioning, if we're suctioning our patient and we're sticking a catheter into their trachea or down the tube and it gets down in that lung area, you should gag, right? If you put your finger back in the back of your throat, you're going to gag. Well, people who have spinal cord injuries, they don't gag, right? You stick something way down their throat and they won't do anything. They don't feel it, right? And that is deadly to them because they cannot protect their airway. So if they don't gag or have that Valsalva ability, then that means anything that's trickling down their throat is going straight into the lungs and they have no protection. So that's causing aspiration pneumonia, and that can cause death. So they always have bronchial hygiene issues. We always have to turn our spinal cord injury or completely paralyzed patients. They're already paralyzed, right? So you ain't damaging nothing. But if we have to kind of turn them to drain them, CPT on them, chest vest, all those issues because they are no longer able to get rid of their secretions. So look at the treatment. Bronchial hygiene is key because if you cannot protect your airway, just think if you didn't have a gag reflex and you were sleeping and I took some water in a water bottle and I just started pouring it up your nose, right? While you were laying on your back. When you start inhaling and getting that to your trachea, you'll get up and cough violently, right? Because your body like, ho, this don't go in here. So your body's trying to protect your airway by coughing violently, right? But if you don't have that ability anymore, then I can pour water straight down your nose and it will go straight into your lungs and you wouldn't even feel it. You wouldn't even feel it. So you cannot protect your airway, right? That's one of our main goals as therapists, to try to help patients protect their airway, okay? And so we have to give them excellent bronchial hygiene. Sometimes we can put a machine on them called the cough assist. A cough assist. We can either give them cough assist by pressing on their stomach, right? They take a deep breath in, and when they're trying to push it out, we can push on the stomach at the same time, and that'll help push some of that secretions up and out, right? Or we have a machine. This young man here is on a machine called the cough assist. And what it does is it pushes pressure in and then sucks it back out. It'll push pressure in and then suck it back out. And that's like giving him an artificial cough. All right. Neuromuscular diseases continue. The next one is polio. Polio was a devastating virus that, a neuromuscular virus that killed a lot of young kids back in the 60s, right? I think the 50s and the 60s. And they finally came up with a vaccine to treat polio and eradicated it. But it causes severe deformity of the bones. Look at these people here. He can no longer stand up straight. He has to walk around on all fours because he cannot stand straight. His legs and bones are just totally messed up, okay? These babies here were shown. They have to be placed on these little extenders to keep them from folding up, okay? Because these kids here in the third world country, they didn't have the medicine and stuff that we have over here. So their body started to crumple up and fold up, but nothing you can do, right? But when we found out these babies had it, we put them in these harnesses that don't allow them to bend. And they have these braces on their knees to keep their body from bending, right? And folding up. Polio was a terrible, terrible disease. It's a contagious disease, contagious virus, kind of like COVID. Terrible. It was new. They didn't know what was going on, and they had to scurry around to find a vaccine. But polio is a contagious viral illness that is most severe form causes paralysis, difficulty breathing, and sometimes death. Today, polio virus continues to affect children and adults in Afghanistan, Pakistan, and some African countries. But how do you get it? From being nasty. That's how you get it. When a person is infected with polio virus, the virus resides in the intestine, in the nose, and the throat. Transmission often occurs through contact with stool of the infected person, known as fecal-oral transmission. So that means you're not washing your hands after you use the bathroom, and you put your hands in your mouth, or you touch something else that somebody else puts in their mouth, and that's how it's transmitted, from feces. Less frequently, transmission can occur through contact with infected respiratory secretions or saliva, known as oral to oral. So if you're kissing somebody, deep tongue kissing, and they got polio, it's possible, less frequent, but it's possible to get it, right? But the main way you get it is through fecal oral transmission. So if you get a question that says which respiratory or which neuromuscular disease comes from the contact of fecal oral transmission, you need to say, oh, that's polio, right? Which drug or which disease could I could benefit from me stopping isopropium bromide? If isopropium bromide is on the regimen of a patient, which disease could they have that I could likely stop this medicine to improve the condition of that disease? You need to say, oh, that's Myasthenia gravis. You got to know this, okay? You got to, this stuff is not for your memory, all right? Not for your memory, but for your knowing. You have to know what to do, not just memorize, okay? All right. Manifestation, respiratory paralysis or weakness. So if your lungs won't do what you want them to do, it's called a restriction, okay? So following the transmission, a person, you don't necessarily become sick immediately, just like corona, right? 7 to 14 days after you have touched something or ingested and contracted polio, then that's when it starts to show up in your body, right? So that's the incubation period, just like COVID virus, 7 to 14 days. So up to 2 weeks before you even feel the effects. And then you might not even feel the effects of the coronavirus. You may be asymptomatic the whole way, but you have been infecting everyone you love in that period. Okay, so going around to I ain't wearing no mask and all this, that, and the other, you could be infecting somebody you love. You might not be sick at all. You might be the picture of health, but full of corona. Okay, you have to be very careful. You have to be. So this starts 7 to 14 days later. Polio can begin. That's the period between the polio transmission and symptoms is called the incubation period, just like any other virus, right? How do we treat it? We have to treat them with the ventilator and bronchial hygiene because they are no longer able to facilitate a what? Cough. If you can't cough, you cannot remove those foreign materials out of your lung. If you can't get rid of the foreign material or the mucus out of your lungs, it becomes pneumonia, it becomes death. So being able to cough and protect your airway is #1 priority, okay? You got to be able to do that, okay? So example, if you go to somebody's house and they having a party, yeah, you wearing your mask, right? But they got chips in the bowl, they got peanuts in the bowl, they got M&Ms, right? They got dip and all these different things on the table. Well, if Mr. Smith goes to the bathroom and boo-boo and does not wash his hands, right? You don't know if he washed his hands or not. He might have on the freshest clothes and all that. You don't know that he nasty. It doesn't always look, they don't have to look dirty to be nasty. The finest person, the richest person can be just as nasty as you could think about, okay? So if he goes to the bathroom and has a bowel movement and does not wash his hands and he has polio, right? He don't know he got polio. Well, he didn't wash his hands, so he has it on his fingers or whatever. He goes and get back into the life of the party, drinking his beer or whatever, dipping his hand in the M&Ms, dipping his hand in the chips. And then you come behind and get you a few chips because you're about to eat you some Rotel, right? You have just contracted his feces into your mouth. Okay? You have to be careful. Never reach into a shared bowl unless it's your kids or your immediate family. Other than that, when you go to a party, never eat out of an open bowl. If you're going to get some chips, you need to open up the chips and be the first one to pour your chips out the bag. Don't reach in and grab them, because studies have been done that show feces on these different things in bars. They go get a few peanuts and stuff from some of these restaurants and these bars. Like I think Logan's has those salted peanuts that they throw at you and all that, and they have you digging your hand in there like it's okay, and you could be very well picking up feces and putting it in your mouth, because everybody don't wash their hands. So that's how polio is transmitted. All right. The next neuromuscular disease is called tetanus. Tetanus. That is when the whole body is completely rigid. Look at this baby down here at the bottom. One person is holding his feet, one person is holding his head. His whole body is just hard as a brick. All of the muscles in the body are contracting constantly, right? Every muscle in the body is contracting. Look at this baby. He's just completely hard, almost like rigor mortis. This man is not dead, but his arms are stuck like he's contracting. That's called tetanus. Okay? So if you have tetanus, can your lungs inflate? No, because they have no room. Your rib cage won't expand because you're so locked down. Okay? So it manifests as constant contraction of the muscles. You don't have good chest expansion. Of course, you're going to have a low tidal volume, low vital capacity, low TLC and inspiratory capacity, like any other restrictive disease. All the PFTs are the same in restrictive diseases, and most PFTs are the same in obstructive diseases. Okay? How do we treat it? We got to paralyze this patient. We cannot treat him until we knock him out. You have to give him some medicine, probably rocuronium or succinylcholine, succinylcholine, called sucks, right? That's what we give patients before we intubate them. So we totally relax them and paralyze them. That's the only way we can treat them. Because right now he's going to be like a stiff board. No matter what you do, it's kind of like a mannequin. That baby and that man is like a mannequin, right? It's no flex, no bend. So we have to give him some medicine that will totally paralyze him. And since we're going to have to paralyze him, we got to put him on a ventilator. Because when we totally paralyze, that's lungs and everything. Nothing's working. So we have to paralyze you, put him on a mechanically ventilator, right? Until his function returns. That's how you treat tetanus. We also have a machine called the iron lung or chest cuirass if there's no other pulmonary involvement. So that's kind of like a ventilator. The iron lung was an old school ventilator that was usually used for polio patients, right? And it's like a big machine that they get in and only their head is sticking out. And what it does is it mimics the effects of the diaphragm. Regular ventilators are positive pressure. We're forcing air in, right? Well, the iron lung it sucks the body like into a vacuum, and it makes the body breathe by negative way, the more natural way. And so, yes, iron lung is better than the positive pressure ventilators, but they were so big and so cumbersome that they stopped using them. But there are still some patients. I looked at YouTube and typed in iron lung. I want you guys to go to YouTube this weekend. Type in iron lung and just see how it looks. It's almost look like a spaceship that somebody used to get in. But that's how you treat tetanus. All right. The next restrictive disease is called the pulmonary restrictive diseases. All of the other diseases we've been talking about have been other issues that affect the lungs or prevent the lungs or restrict the lungs from doing their job. But we also have some restrictive diseases that are of the lung themselves, okay? Now we're talking about issues with the actual lung. Pulmonary edema, that's one. If there's water in the lungs, then there can't be air in the lungs. So if your lungs are full of liquid, then they won't breathe like I want them to breathe, so that's considered restriction. Acute respiratory distress syndrome, also known as ARDS, one of the most debilitating lung disorders you can have. It's acute, right? It can happen really quick from something that you breathed in or whatever you were around, and you go into ARDS, and that can kill you. ARDS have to be on a ventilator. They are considered critical illness, right? They're in critical condition, and you have to put them on a ventilator. Interstitial lung disease, ILD. Interstitial lung disease, and you're going to see what that comes from. And then simple pneumonia, when you have some secretions or mucus in the lungs that have become infected. That's called pneumonia, right? And in those areas, in your alveoli, if you have fluid in the alveoli or mucus, then there's no air, right? And so if there's no air, your lungs won't inflate because you don't have any room for air to go into your lungs. So that is a restriction. So let's look at these in detail. Pulmonary edema. This is a cross-section of an alveoli. This would be a cross-section of an alveoli, right? Cut in half. Look at all that, it looks like a wonderful bubble bath, right? But this is pink frothy secretions. Remember, pulmonary edema manifests as pink frothy secretions, right? They're not just liquid, they're kind of frothy, like suds from a beer. Now, going back to pharmacology, what medicine can we give to break the surface tension down of those bubbles in pulmonary edema? What drug do we give that fights pulmonary edema? It works by breaking down the surface tension of the bubbles, turning them into liquid so that we can suction them out. What drug do we give for that? I'll give you a moment to think of it. Gabrielle, you know? Anybody know the drug that we use to treat pulmonary edema? Because believe me, you're going to have these same pharmacology questions on your final. They're going to be on your oral, on your board exam. You cannot forget this stuff, guys. We just did it. All right, the answer is vodka. ETOH, ethanol alcohol. Ethyl alcohol is what we give to break the surface tension down of those frothy secretions in the lungs known as pulmonary edema. When the patient has pulmonary edema, we can inhale vodka. Talked about that in length, right? You gotta, like I say, I've said to them, I'm blue in the face. You have to know what drug you give for what situation. We just talked about it. All right, so pulmonary edema results from excessive movement of fluid from the pulmonary vascular system to the extravascular system and the air spaces of the lungs. So those pulmonary veins, right? The pulmonary veins take oxygenated blood back to the heart, to the left side of the heart. Well, we have left-sided heart problems or heart problems in general, that can cause a backup, right? And so if the blood coming back from the lungs starts to back up, it goes back into the pulmonary veins, the pulmonary vasculature. And so much of it will start to leak out of the pulmonary vascular system and leak back into the alveoli. And so now you got frothy secretions inside the alveoli where there should be nothing but gas, right? And so now we have pulmonary edema. But we can't simply go in and just suck that out, because if you suck the bubbles of a beer, you're not going to get anything but air, right? And so we have to break the surface tension of those bubbles so we can suction them out, turn them into a liquid so we can remove them from the lungs, right? So we have types of pulmonary edema: cardiogenic or hydrostatic, right? Cardiogenic or hydrostatic, like I just said. Left-sided heart failure, commonly known as CHF. If it's a heart problem, it's called cardiogenic or hydrostatic. Okay? Cardiogenic or hydrostatic. Let me make sure. Yeah. Cardiogenic or hydrostatic. That's when it's a cardiac-related pulmonary edema. So cardiac-related pulmonary edema is called cardiogenic or hydrostatic. It comes from left side heart failure. Like I just said, when the left side of the heart or the left ventricle is not pumping like it should, then the blood starts to back up into the pulmonary, from the pulmonary left ventricle into the left atrium, and then back into the pulmonary veins. That blood then, or that fluid then, starts to leak out of the pulmonary veins into the chest, right? Which is a leak into the alveoli. And that's pulmonary edema because of the heart, right? You have causes arrhythmias, right? If you have systemic hypertension, somebody who has high blood pressure. If you have congenital heart defects, excessive fluid administration, if you gave the patient too much fluid, right? If the nurse is giving boluses of IV, boluses of normal saline, and they're giving too much, then the heart can't keep up with it and it starts to back up. Okay, you have to be careful with that. What if they have mitral valve or aortic valve disease? That's on the left side, right? The bicuspid side is the mitral valve. So you got to know that the bicuspid valve is on the left side of the heart, right? Between the left atrium and the left ventricle. That's the bicuspid valve or the mitral valve. If that valve is dysfunctioning, then that can cause a backup in the blood. Or if the aortic valve is malfunctioning, that causes a backup on the left side, right? So those systemic problems are called cardiogenic or hydrostatic pulmonary edema. And then finally, a heart attack. If you had a heart attack, that can cause the pulmonary edema. But what about if it's not a heart problem? How do I get pulmonary edema if it's not a heart problem? This will be known as non-cardiac pulmonary edema. Non-cardiac pulmonary edema is also called non-cardiogenic or non-hydrostatic. And this can come from increased capillary permeability. If the capillary, you know what permeable means? It means something can go through it, right? You think about a mesh, something kind of mesh that's on your shoes, right? And you drip some water on the mesh. Usually it'll roll off, but some of it can go through because it's permeable, right? Permeable means you can get through it. So if you have a problem with your capillaries, remember your capillaries are linings, are lined all upon your alveoli. And if those capillaries become more permeable, then now fluid can kind of ease in and out of the capillary into the alveoli. So that causes some fluid, right? And that's known as can cause alveolar hypoxia. It can cause acute respiratory distress syndrome known as ARDS. What about inhalation of toxic agents, like you breathe in some chlorine, sulfur dioxide, nitrogen dioxide, ammonia, phosphogen, right? You working somewhere with toxic things like that, you breathe that stuff in, that can cause increased permeability in your capillary, right? That can cause your capillary, the walls of the capillaries to become more permeable. And the more permeable they are, the more fluid can go in and out of them. We don't want that, right? We don't want that. We just want the gas to exchange. We don't want the fluid to exchange, right? Pulmonary infections, like if you had pneumonia, that can cause increased capillary permeability. Therapeutic radiation, if somebody has a lung cancer or some type of cancer and you have to have radiation on that cancer, That radiation can cause increased capillary permeability. Acute head injury, known as cephalogenic pulmonary edema. If you have a head injury, that can cause all kinds of problems, right? That brain injury can cause all kinds of problems. People can have high fevers, they can sweat a whole lot. They call it a neurologic crisis, right? And it can just cause all kinds of problems. Your brain injury can cause a body to heat up to 105, and you don't even have an infection, right? But it happens because of a brain or head trauma, okay? So all those things I just named can cause increased capillary permeability, all right? So that's not the heart causing it, right? So since the heart is not causing it, it's called non-cardiac pulmonary edema, also known as non-cardiogenic or non-hydrostatic. What's another reason for the non-cardiogenic? And that would be lymphatic insufficiency. Lymphatic insufficiency occurs when normal lymphatic drainage of the lungs is decreased. The lungs should be able to drain, right? You should be able to drain into the lymph nodes. But when that doesn't happen, that the fluid stays in the lungs. And if that fluid stays in the lungs, that's edema, okay? So what causes lymphatic insufficiency? Damaged or distorted lymphatic vessels. If they're obstructed by tumor cells, or increased system pressure may slow, right? So increased system pressure may slow the lymphatic drainage, okay? And then finally, decreased oncotic pressure. Now, what is oncotic pressure? Oncotic pressure is the opposing force to hydrostatic pressure, right? It's the pressure that pulls fluid into the vessels. So if the lungs have a little fluid in them, then you should have a good oncotic pressure that draws the fluid out of the alveoli and into the interstitial space, okay? That's where we want it. We don't want it to be inside the alveoli. All we want inside the alveoli is gas. Now, there may be a little bit of fluid in there, here and there, but we have good oncotic pressure that allows it to suck that out, right? It drains that fluid out of their alveoli and puts it in the interstitial space, right? That's where we want it. Well, if we have a decreased oncotic pressure, then the force that was pulling or drawing the fluid out of the alveoli is low. It's not there anymore. So now it doesn't have that effect. So the fluid stays in the lungs, which is pulmonary edema. How does it manifest? Interstitial edema, right? We started seeing interstitial edema. That's when you, if it's so much, so it can start being in your arms. You start pushing on your arms, and if you press down on your skin and it leaves a finger mark, that's edema. That's pedal edema. It can get all the way down to your limbs, okay? Or regular interstitial edema will be fluid in the interstitial space, right? Too much fluid in the interstitial space. We talked about there's 3 types of fluid in the body. Interstitial fluid, which is the fluid in between the cells. Intravascular fluid is fluid inside the vessel. And then interstitial, intravascular, and intracellular would be the fluid inside the cell, okay? Coughing. The body may start doing a lot of coughing because the body's recognizing this fluid in the lungs and it wants to get rid of it, right? You don't want fluid in your lungs, you start to cough, excess coughing. How does the fluid look? I told you it's frothy, white or pink secretions. Frothy, not liquidy, it's frothy, right? You may even have paroxysmal nocturnal dyspnea, but you don't have to worry about that. But that's kind of like orthopnea. Orthopnea means how many pillows do you have to have in order to breathe right? Can you sleep flat on your back? If you can sleep flat on your back, or you can lay flat on your back and you don't have any breathing issues, then you are not orthopnic. You have no orthopnea, okay? But some people say, oh, Lord, no, I can't lay on my back at all. If I lay on my back, I get short of breath. I have to sit up. or I have to sleep with at least 3 pillows, 4 pillows, 5 pillows, right? That's the degrees of orthopnea, all right? Orthopnea is not able to breathe by laying on your back, right? That's a term you need to know, and it's in this recording. PFTs. PFTs will show reduced volumes and capacities, just like any other restriction. Increased hemodynamic pressure. So you'll learn that when you get to hemodynamics. But I told you there are several pressures inside the heart, inside the lungs that you're going to be learning as you go on through respiratory, and that's in your hemodynamics. And then a chest X-ray. The chest X-ray usually shows bilateral infiltrates, cardiomegaly, curly A and B lines, bat wings or butterfly patterns of fluid, and pleural effusions. The chest X-ray, again, that's not going to be on your exam. That's a little bit further as you go into a little bit further when you start studying chest X-rays. Okay, I think that's 220. When you start studying chest X-rays, we treat it with medicine, right? We can give medicine which will preload reducers, right? Nitroglycerin, loop diuretics, right? Diuretics are drugs we give to reduce fluid, right? So we can give diuretics, we can give morphine. Sometimes they give morphine to reduce the feeling of hypoxia. Then we can give afterload reducers, right? Usually like blood pressure medicines, inotropics, albumin, stuff like that. You don't have to know all of the medicines for pulmonary edema. You learn that a little bit farther as you go a little farther. But oxygen, we give medicines, we give oxygen, good bronchopulmonary hygiene, suctioning them out, right? And if I can't suction it out, I can give him some alcohol, right? Ethyl alcohol breathing treatment that will reduce the surface tension of those frothy secretions to where I can suck them out, okay? Hyperinflation, look, lung expansion therapy can treat pulmonary edema, because what happens is positive pressure, you need to write this down and make sure you highlight this. Positive pressure will force the fluid out of the alveoli and into the interstitial space, because diuretics cannot enter into the alveoli. I don't know if you know that, but now you do. If you take medicine or diuretics, it cannot affect inside of the alveoli. The only way we can affect the fluid in the lungs is if we force it out of the alveoli into the interstitial space. Once I push it out of the alveoli into the interstitial space, then I can pick it up with a diuretic, okay? So I want to give them some positive pressure like a CPAP mask, right? This will be a little bit more than your just regular positive pressure breathing hyperinflation. We're going to put them on a mask, right, to make it, because it's going to be a little longer term that we have to deal with it. So we put them on a non-invasive mask called a CPAP mask, continuous positive airway pressure. CPAP is continuous positive airway pressure. It's a little CPAP mask that, what? Positive pressure will push the fluid out of the alveoli into the interstitial space. So we use a CPAP mask as most popular and has been proven to improve the symptoms and reduce intubation, right? Because once you start filling up with fluid, you're like, I can't breathe. I need some help. I can't breathe. They start panicking, and we have to knock them out and intubate them. That's put the tube down the throat and put them on a machine. But that comes with a lot of risk as well. So in order to try to reduce the amount of intubations, we can do something non-invasive first, right? Because intubating is an invasive procedure. But if we want to do something a little less invasive, then we can do the CPAP mask, which will force them having constant positive airway pressure, right? And that positive pressure will force the fluid out of the alveoli into the interstitial space where the diuretic can work, okay? We can also put them on a ventilator if we have to. Again, if that doesn't work, we can go straight to the ventilator, right? We can use bronchodilators if we have to. But they're, let me see, will usually be ordered, but are not effective unless the patient has underlying chronic respiratory condition that involves bronchoconstriction. So if they don't have bronchoconstriction, then bronchodilators don't work. A lot of times doctors or nurses, can you give them a breathing treatment? They want a breathing treatment for everything, right? We only give bronchodilators when there's wheezing or there's bronchoconstriction. We don't give bronchodilators for coughing. We don't give bronchodilators just because he's short of breath. But if he has bronchoconstriction, then we're going to give a bronchodilator. So we can give it in pulmonary edema issues if they have some constriction along with it, okay? And here's the big one right here. Inhaled ETOH, that's vodka. Inhaled vodka reduces the surface tension of the frothy secretions, like I've been saying. And how would I have the patient sitting? Would I have him on his back? No, he barely can breathe. So you have him in a Fowler's position, which is sitting up, like sitting in a chair. You have the head of the bed raised up so he can sit straight up, okay? That helps his breathing. ARDS is another pulmonary issue. ARDS. Now, we can have direct injuries to the lungs and direct injuries to the lungs that cause acute respiratory distress syndrome. That's why it's called acute, because something happened fast and caused the lungs to go down hard, okay? Something like a direct injury to the lungs or pulmonary injury will be like viral or bacterial fungal pneumonia. If they have a real bad pneumonia, it can damage the lung, causing you to go into ARDS. If you gastric aspiration, what we talked about yesterday, if somebody vomits into a tracheoesophageal fistula, right? The vomit can go through the fistula into the lungs. If you get vomit, which is gastric contents, into your lungs, that can cause ARDS, because that is acute damage to the lung because your hydrochloric acid is in your stomach. Hydrochloric acid can melt a lot, almost melt copper, right? It's very, very strong, but it's in your stomach, right? But if it gets out into your lungs, it's damaging those lungs bad. So that's what happens with people who OD. Somebody's on a drug and they OD, and they land on their back. When they start coming around, they may vomit and they inhale it right back in because they can't turn over because they're weak and OD. And a lot of times that vomit that gets into their lungs is what kills them from ARDS. They go into ARDS, nobody knows where they are, and they find them dead with dried up throw up on their face, and they're dead. Okay? Just like drowning, near drowning. When you mess around and get a little too much water or that chlorine water in your lungs, that can cause ARDS. And then, of course, a lung contusion. If you get stabbed or shot and there's a contusion into your lung, or if you have a car wreck and one of your ribs break and poke into your lung, that's a contusion. That can cause ARDS. That's a direct injury. All right? Now, some of the indirect injuries that are non-pulmonary reasons why you would get ARDS will be sepsis or prolonged shock. When you have if somebody has an infection in their blood, they can become septic, okay, and go into shock. And if you're in it for too much time, that can lead to ARDS. A burn, if you're in a house fire or a chemical fire, burn injuries to the outside of the body can cause ARDS. Multiple traumas, transfusions, right? You mess around and get a blood transfusion and your body reacts negatively, that blood can damage the lungs and you go into ARDS. Pancreatitis, and then gynecologic issues from women, like abruption of placenta, amniotic embolism, or eclampsia. So gynecologic issues that are acute can lead to ARDS in women. Drug effects, like transretinic acid for acute leukemia. So you don't have to know all that, but drugs, you get a bad reaction to a drug can cause ARDS. And then sickle cell. Some of your sickle cell patients that go into a sickle cell crisis can, if we don't get a hang on it, can lead to ARDS, which is acute respiratory distress syndrome. And all of this keeps the lungs from doing what you want them to do, so they're considered a restrictive disease. All right. The manifestations of ARDS, you have interstitial and intra-alveolar edema and hemorrhage. That means your alveoli are bleeding. Alveolar consolidation, right? They start to be full of blood and full of whatever the fluids are. Intra-alveolar hyaline membrane formation, and those kind of like extra tissue that's formed inside of the alveoli that further block your breathing. Pulmonary surfactant deficiency, right? Remember we said pulmonary surfactant is what allows the lungs to stretch. But once you have ARDS, it can cause a lack of surfactant, which now makes the lungs have a low compliance, which is a restriction, okay? And you can tear the lungs if you try to ventilate them with too much volume. You can rip them, cause barotrauma, right? And pulmonary embolus, pneumothorax, right? Because now they were a wet sponge, but now they've gotten ARDS, and now it's like a dry sponge. If you try to stretch a dry sponge, you're going to tear it, all right? Because the surfactant is not there. And then, of course, atelectasis. Some of the clinical data you will see with somebody in ARDS, they're going to be breathing fast, tachypnea, decreased lung compliance, of course, because it's a restriction. Retractions, that means they're using accessory muscles to breathe because they can't breathe. Refractory hypoxemia. What do we say refractory hypoxemia means? What does refractory mean? Refractory, what is refractory hypoxemia? Something that's refractory or refracted, what does that mean? Refractory hypoxemia means it doesn't respond to treatment. A hypoxemia that does not improve with oxygen. That means it's refractory. Refractory means it does not respond to treatment. And how do we treat hypoxia? Giving oxygen. So if you have a patient who is hypoxic and you give them oxygen and it still does not improve, that's refractory hypoxemia. You guys should know that. Cyanosis. What cyanosis mean? Surely you know that. What does cyanosis mean? Maybe you guys are on a little break. Okay. Cyanosis. Judith, what cyanosis mean? Are you there, Judith? Cyanosis is blue color.
Blue color.
Yeah, thank you. Patient is turning blue. Dull percussion note. That means when you're tapping on the chest, it sounds dull. A dull resonant sound means consolidation is there. They might even have crackle sounds when you're listening to the breath sounds, right? So those are some of the clinical data that you would see in ARDS. This patient is critical. This patient is critical. So we'll treat them with oxygen. We try to keep them on less than 60% oxygen, but we use PEEP, okay? We also use a rotoprone bed. That's a lot of times patients have been shown to increase their mortality if you lay them prone. Yes, they're on a ventilator, but they land on their stomach instead of their backs, okay? And so we have a special bed called the rotoprone bed that turns them. It's kind of like a rotisserie chicken, right? You got the patient laying there on the ventilator and it turns. They have them on their stomach and then it'll turn them back on their back. They have them prone, supine, prone, supine. We can also give inhaled nitric oxide. Nitric oxide is known, which you don't have to know that what it does, but nitric oxide dilates the pulmonary artery. So it allows more blood to flow through the pulmonary artery, which increases the chances of oxygenation, because the more blood that can get to the lungs, the more hope that it can pick up oxygen. Lung expansion, we use PEEP at optimal levels. You'll learn what optimal PEEP is later, okay? But lung expansion, mechanical ventilation, got to be on the ventilator. Now, what's special about the ventilator for ARDS, we will have them on small tidal volumes, but high respiratory rates, because we want to maintain a good minute ventilation, but we don't want to damage the lungs. And we already said that ARDS could happen to have a lower amount of surfactant in the lungs. And surfactant is what allows the lungs to stretch. So if the surfactant is not there, then the lungs are not able to stretch like they used to, right? And so we don't want to try to overstretch them by giving too much volume, right? Regular tidal volume is around, 400 to 500. You definitely cannot do that with somebody who has ARDS. Well, since I'm not going to give them a lot of volume, I have to make up that minute ventilation by increasing the rate. All right. So since I'm going to come down on the volume, I got to go up on the rate. So now I may have somebody breathing 30 times a minute with a tidal volume of about 150 to 200, instead of somebody breathing 12 times a minute on 500, right? I'm still going to maintain a good minute ventilation, but I'm not damaging the lungs because they're already very, very ill, okay? Some IE ratio inverse, you'll learn it a little later. Permissive hypercapnia and high frequency oscillation ventilation. That's simply a ventilator that breathes like almost like a baby, right? But that will be more of your severe cases. We really don't do that much, but that's a possibility, okay? That's a possibility. And I think this is the last one, which is pulmonary disorder. The pulmonary will be ILD. Restrictive disorders, remember we're talking about pulmonary disorders now. ILD, interstitial lung disease. Now these is the kind of crazy one here. It's got all kind of weird ways or weird different diseases that I never knew even existed. But it manifests by the destruction of the alveoli and adjacent pulmonary capillaries. You start destroying your alveoli because of what you breathed in, right? You have thickening of the respiratory bronchioles, alveolar ducts, and the alveoli. So you can destroy them. They can get hard and thick, right? You just turn up your lungs by what you're inhaling. Chest x-ray. You're going to learn with these chest x-ray as you get into 220, okay? But fibrocalcific or fissile pleural plaque, right? So you have calcium and all that kind of stuff building up on the lungs, especially if you worked around asbestos. I know you all have seen commercials where people are talking about mesothelioma, right? They have lawyers on TV always talking about, did you a loved one die from mesothelioma, right? That comes from being around asbestos, which they used to use in production in Navy yards and ship making boats and stuff. They use a lot of asbestos. A lot of schools were made with asbestos, and they had to break them down and remove all of the asbestos out of the schools because it was causing lung problems, interstitial lung disease or cancer, okay? It causes bronchospasms, excessive bronchial secretion, right? PFTs, which will be regular restrictive disease process, right? This DLCO, you'll learn that more when you get to PFTs. But what causes this ILD? The causes of interstitial lung disease, known as pneumoconiosis, right? From occupational, environmental, and therapeutic exposures. Now, you won't have to know all of these different exposures. Just know that it's a lot of them, right? You can get it from asbestos, working in the coal mine, silica, right? Beryllium, dust from certain plastics, right? Ceramics, rocket fuel. If you're working in all these different, because when the United States went into the great industrial revolution, right? It's when we started really making a lot of industry, a lot of factories. a lot of factories here in Memphis that are closed down, like on Kansas Street and Tennessee Street. All those streets downtown, those big, huge factories that are closed down now. A lot of those worked and made these different products, right? And so when we got into that, we didn't know that we had to wear a mask around these different things. So a lot of our citizens suffered from mesothelioma and from interstitial lung disease because they were breathing in this stuff. What about mushroom workers' lung? There's a disease called mushroom workers' lung from working around a lot of mushroom compost. Farmer's lung from being a lot of moldy hay. Woodworkers' lung, huh?
Even though we eat mushrooms, they
No, they're working around compost all day, breathing mushrooms all day at work every day. Farmer's lung from being around a lot of moldy hay. Woodworkers' lung, working with wood pulp. We make paper out of wood pulp. That's how we make paper. Paper, you know, is made out of wood. Bird feeders' lung, right? Bird droppings and feathers. So if you're working in a chicken house, right? Well, they slaughter the chicken. They raise the chicken and slaughter it, and and produce it, debone it, and wing it or whatever. The feathers and all of that. A chicken plant. So if you don't have the perfect mask on or the right type of mask, you can suffer from bird breeders' lung, which causes interstitial lung disease. Animal handlers' lung from rats and gerbils. Chemical workers' lung that work around paint, resins, and plastics, right? So there's a lot of things that can cause interstitial lung disease. It's mainly from your occupational exposure. So when you get a question about this, it may say which restrictive disease manifests from exposure to occupational or environmental exposure. You're going to say, oh, that's ILD, that's interstitial lung disease. I'm not going to ask you which one comes from working around birds. I'm not going to ask you those specific ones like that. But just you need to know that ILD comes from working in occupational and environmental exposures. What about illicit drug use, right? Or medications. Some antibiotics can tear your lungs up, okay? Some anti-inflammatory agents like aspirin, methotrexate, but other things like ibuprofen, that's an anti-inflammatory. You have to be careful. Too much of that can cause ILD. Cardiovascular agents like amiodarone, which we give in ACLS. You'll learn that when you get into ACLS or your cardiac drugs in your advanced pharmacology coming up in 230. You did pharmacology with me. You're going to do advanced pharmacology when you get to 230 or 240, one of those. But they talk about cardiac drugs, and amiodarone is one of them. Illicit drugs like heroin and methadone. Heroin and methadone can cause ILD. Radiation from cancer, of course, and irritant gases like chlorine, ammonia, ozone, all those type of things, right? Be very careful wherever you're working. I know they may say they got a fire job. Oh, this company making $18 an hour, making plastic carpets or plastic, but you never know but they don't give y'all no mask or nothing. You smell it, but you don't think it's no problem. Over time, it can be destroying your lungs, okay? Because we're all about industry. We're all about making here, buy home. That's why a lot of them went to other countries, because they start killing them off instead of themselves. I know that the production of my product is going to be toxic, so I'm going to keep that away from here because the United States won't let me release this into the atmosphere. But if I go to another country, I can. And I can pay the people cheaper. So any businessman or woman would go to another country. But now that we're bringing things back, we have to be careful about our health when we are producing these things. I'm all about buying here, but you need to be very careful what you're inhaling, right? So what other causes? Idiopathic interstitial pneumonia. No readily identified specific exposure underlying the genetic cause. Idiopathic pulmonary fibrosis, cryptogenic organizing pneumonia. You don't have to remember none of these. You don't have to remember any of these right here. None of this is on the test. It's not 210. All right, none of these little causes right here. Don't worry about this page. How do we treat ILD? Corticosteroids, because you're going to have inflammation in these diseases. Interstitial lung disease is going to have a lot of inflammation. So we use corticosteroids to treat the inflammation. We give you oxygen if you become hypoxic. If it's real bad, we put you on a ventilator, right, until we can fix your lung or get you better. Pulmonary rehab, and then finally a transplant. If you've been around, you know, my granddaddy been working in the chicken house for 50 years, right? But he can't breathe, hardly breathe at all, right? And that's why he can't breathe, because he's been around that bird breeders. He got bird breeders lung, okay? And then a transplant if needed. And this is the last one, pneumonia. Pneumonia is the last restrictive disease that's under the pulmonary category. Pneumonia. Pneumonia will manifest as a loss of volume, restrictive disease, of course, inflammation of the alveoli. Basically, you need to know that pneumonia can be either bacterial or viral, okay? Usually, the fever, right? Hyperthermia, also known as fever, or also known as febrile. A fever of a little bit more than greater than 101 is usually bacteria, and less than 101 for viral. Okay? So if you want to know the difference between viral pneumonia and bacterial pneumonia, well, first thing you can do is get a blood cell count, right? A CBC, which looks at the white blood count. If it's a bacterial pneumonia, then your white blood cells will be up, right? If it's a viral pneumonia, the white cells will either be normal or low, okay? But another way to look at it is his fever. Check the temperature. If you've got pneumonia and that temperatures are greater than 101, it's probably bacterial. We'll treat it with antibiotics. If it's less than 101, so say he like 100, fever of 100, you know, low grade fever, and it's viral, then that would, and it's pneumonia, then it would be viral pneumonia. You can't treat that with antibiotic. You have to let it take its course and do some other antivirals that are out there. Cough starts with a hacking cough, non-productive, that changes to productive over some time. And you may even see some blood or rust color. Rust means older blood, right? It's a little bit older, okay? Increased tactile or vocal fremitus, dull percussion. That means when I tap on the lungs or tap on the chest with my finger, right? That's called trying to assess your patient. I can feel his chest, right? I can put my finger on his chest and thump my knuckle. And if I feel a dull sound, I hear a dull sound, that means it's full of fluid. A hyperresonant sound, hyperresonant means air. Hyporesonant or dull means consolidation, right? Of course, if you do a chest x-ray may show air bronchogams and pleural effusions. Main thing is you got two types of pneumonia, either bacterial or viral. Okay, either bacterial or viral. If it's greater than 101, it's probably bacterial. If it's less than 101, it's probably viral. It may be viral or fungus, but you won't hardly ever see the fungus one. Now, the types of pneumonia. Community-acquired pneumonia is CAP. That's acquired from normal social community contact. That's stuff you get pneumonia out there in life, right? Pneumonia that you get from other people out there in life, right? It can either be streptococcus pneumonia or staphylococcal pneumonia. You won't have to know that. But you do need to know that CAP, a CAP, is community-acquired pneumonia, and a HAP, HAP, is hospital-acquired pneumonia. And that's when you get it from the nosocomial infections lead to pneumonia, right? Whenever you come into the hospital and you didn't have pneumonia, but you got it while you were there, then that's hospital-acquired pneumonia. And it's caused by being in the hospital environment, okay? You can also have a VAP, which is a ventilator-acquired pneumonia, right? You might have got into the hospital, never got pneumonia, but when we put you on a ventilator, then you develop pneumonia, then that's a ventilator-acquired pneumonia, which is a VAP. And that usually happens about 2 to 3 days after we intubate you. So we want to keep the head of the bed up 30 degrees, change the circuit when it's soiled, only suction when you need to, change the inline nebulizer every use, and use appropriate oral care. You got to wash their mouth, and they have products for oral care to keep their mouth clean, because your mouth is nasty. Your mouth has more germs than your anus. Okay, so you have to be very careful with those oral secretions leaking down into the lungs. They cause pneumonia, especially now that you have a tube down your throat. It makes it even more easier for them to get there. Aspiration pneumonia, of course, is when you aspirate gastric fluid. Okay, chronic pneumonia is associated with granulomas and tuberculosis and fungal pneumonia. So that's somebody who always got pneumonia. They just always keep getting it. That's chronic pneumonia. All right, necrotizing pneumonia is localized pus formation and necrosis within the pulmonary parenchyma. Now, we said the parenchyma is where the magic happens. So if the pneumonia is down in the parenchyma part of the lungs and there's a lot of pus, that's called necrotizing pneumonia. Now, the test won't ask you all these different types like this. You just need to know that pneumonia is either viral or bacterial. It's a pulmonary category restrictive disease, right? That's the main thing, to know which disease is what. You got these different types. You have skeletal, abdominal, right? We have pulmonary, and what was the other one? I think that was it. Skeletal restrictive diseases. You have abdominal restrictive diseases. Then we have pulmonary restrictive diseases, right? And I'll go back over to make sure that's all of them. But you got to know that the difference between restrictive and obstructive. So you have to go back and look at the video for everything you've missed. How do we treat pneumonia? Oxygen, lung expansion therapy to help get secretions up, right? When you do hyperinflation therapy, which will help mobilize them secretions. Bronchial hygiene when appropriate. You may even have to do a thoracentesis. If it's a lot of fluid or a lot of pneumonia is there, we may even have to stick a needle through that spot of the lungs and drain that pneumonia out that way, okay? That's a thoracentesis. Antibiotics when appropriate. If it's viral, you don't give antibiotics. If it's bacterial, then of course we would. And then prevention. Try to keep the patient cleaner, especially for those CAPs, which are community-acquired pneumonias. Keep them, teach them how to keep their hands clean. Be careful who you're around. Those type of things are very, very important. That has concluded the restrictive portion of RT210J. You have covered everything, okay, for RT210J. Your test will be Tuesday. Monday is lab day. You need to come to lab at 2 o'clock. Lab's going to start at 2 o'clock for hyperinflation. All right. Mr. Boyd will be doing the lab with you. And on Tuesday, we will have the exam and give you a chance to make up a couple of labs that you need, that you may need to make up. But I sent you an announcement and an email on the details of the makeup lab. So you're going to be responsible for that. Don't come to me saying I need to make up this, this, and this, and you just telling me when you get here. That's not going to work, because I can't do 100 different labs for 100 different people in one day. We cannot do that. So it's going to be your responsibility to follow the requirements in the announcement that I made today and in the email. It's the exact same thing. I sent you an email and copied it to the announcement. All right. This is the end. I'm going to stop this recording for the day. You are done for the day. And I'm going to have you have a great weekend. I'm about to put this video up, and I'm going to put your homework up for the weekend. The homework will be due Sunday by midnight. It won't be due tonight, but as long as you turn it in by Sunday at midnight, you will have the credit. If you don't do it, then you are going to miss points. It's going to be the rest of the homework, okay? 3 and 4, I believe. If you did 1 and 2 already, it's going to be homeworks 3 and 4, I believe. But check your Canvas for the exact homework to turn in by Sunday. If you don't turn it in, they're 25 points apiece. I think there are 4 of them. So if you turn all of them in, that's 100. If you only turn one of them in, that's a 25. All right, so that can greatly affect your grade. Be sure that your work is visible, that I can see it. Don't start getting too comfortable with just sending me anything, okay? Because if I can't read it, I can't grade. All right, have a good day. I will see you on Tuesday, but Mr. Boyd will see you Monday at 2 o'clock.